We're so glad today to welcome Dr. Margaret Ferris. She is a movement disorder specialist, and that's that uh, rare kind of neurologist who has additional fellowship training in movement disorders such as Parkinson's disease. And she's relatively new to Stanford, only been here less than a year, I think, right, Dr.
About
Ferris?
6 months now.
Yeah, and she comes to us from the University of Maryland. That's where she did a lot of her internship, residency, and the fellowship in movement disorders. So we're so glad to have her here today. She knows a lot about deep brain stimulation and something called focused ultrasound. So we're look forward to hearing from her about both of those topics. And if you have any questions, please put them in the Q&A box and I'll monitor that as we go along. And I will also make sure that the chat is on. Yes, everyone. Okay, so I think the chat is on as well this time. So we look forward to hearing from those of you with questions and let us know as we go along. So take it away, Dr. Ferris.
Yeah, I just want to say thank you all for having me here. I really love talking about deep brain stimulation and focused ultrasound, which is newer, but it's something that I specialize in. And I like to share it with people. So I've really made this setup, this talk set up aimed at the patient perspective. Really talking you through what you would go through if you wanted this and why you might make the choice to have one of these procedures done. I did not focus too much on the science, but if there's any questions where you want more details, I'm happy to go into that. I just thought it's already a lot of information and it could be overwhelming. And if you have any questions, you're welcome to contact me afterwards as well to discuss. So I'm going to start by, there we go, talking about deep brain stimulation, an overview of it, and go through a lot of the details, and then focused ultrasound, and I'll compare the two. And then I'm going to try to give you time for questions at the end as well. But please feel free to add questions into the chat if you have any during the talk. So start with, what is deep brain stimulation? So essentially it is an adjunct to medication for the treatment of various movement disorders, namely Parkinson's disease, essential tremor, and dystonia are the three main diseases we treat with it, though it actually treats lots and lots of things. We use it in psychiatry and other things as well. It's an implantable electronic device. So we have wires that go down into the brain, and then there's a wire that connects it to a battery and a programmer that's in your chest. There are benefits to it, which is that it is reversible and adjustable, and sometimes it can decrease the amount of medications that you have to take. So deep brain stimulation sort of started to come out in the 1990s, and it was approved for essential tremor in 1997, and then for Parkinson's disease in 2002. Since it came out and started being used, it really has become one of the standard therapies that we use. And it will be offered to most people at some point when they have Parkinson's disease. Not everybody is a candidate, but most people will at least want to have that discussion. And it is the most common form of brain surgery that we use for both Parkinson's disease and essential tremor. There are other ones that we can do, though they are not very common anymore since the advent of DBS. So deep brain stimulation has that wire that goes down into the brain, and that wire drives an electrical signal, and it can be placed in a number of different places in the brain, and the different places have different therapeutic effects in different diseases or in Parkinson's disease. So here's a picture of two brains side by side that sort of match each other. On the left, you see a real human brain that's a postmortem, and on the right side, you see a drawing. And I'm using this to point out just a few of the areas that it targets. So this first one up here on the right is called the VIM, and that's going to be in this area on the brain. The GPI, also known as the globus pallidus interna, which is down here, and then the subthalamic nucleus, or the STN, which is down here. And that's what this top one is circling. The STN, or subthalamic nucleus, is a small sort of almond-shaped structure that's next to the substantia nigra. And you may have heard of the substantia nigra because that is where most of the dopamine neurons in the brain reside. And that's what dies off during Parkinson's disease, are those dopamine neurons. And this structure, the STN, is right next to the substantia nigra. And all of these structures together form a network that helps to control movement, both tremor, the increased movement or dyskinesia, and decreased movement like bradykinesia, or that slowness and stiffness that happens in Parkinson's disease. And the STN just happens to be the most common one that we use, but people may have DBS implanted into the GPI or the VIM in cases where you're really just trying to treat tremor. The most important part of the DBS, there are two pieces to it. And this key one here, this is a picture, is the lead, which is the wire that goes down into the brain. So this is tiny. And each one of these little metal things is an electrode where we can send out electrical stimulation from it. The most commonly used leads right now tend to be Boston Scientific or Medtronic. And most of them have 4 leads, though some of them have 8, and soon to come out with some 12 electrode leads as well. On the Boston and the newest Medtronic, these are directional, which means we can aim the electricity in different directions. And that little part here, this with the metal, is supposed to span that place, that STN or that GPI goes through it, so that those electrodes are in the area that we want to get to. The second part of the deep brain stimulation is called a pulse generator. Sometimes I refer to it as the pacemaker for the brain. And it gets implanted into the chest below the collarbone under the skin. And you can actually feel it when it's in there, just like you would feel a pacemaker. Interestingly, we tend to put it on the right side because pacemakers are often put on the left side, and we want to leave room for that if you ever needed a pacemaker as well. And that is basically about battery and a controller that is controlling the electrical signals that go into the brain. Here's a picture of it all put together. So you see the electrode, and the lead up in the brain. There's a wire. This is all under the skin, even though it looks over the skin in this picture. It's all put under the skin and connected to the pulse generator. And the lead, to keep it from moving around in your brain, there's a little cap that replaces the area of skull that gets drilled out, and the wire gets fixed to the cap so it doesn't move around. And it is under the skin, but it moves well with your skin. So why would one get a DBS surgery done? And it's mainly for symptomatic improvement. So symptoms that we can see that are improved by the surgery are, first and foremost, tremor is very responsive. And sometimes the tremor reduction can actually be better than you can get with medication. Some people have sort of tremor that doesn't respond very well to medication. And in those cases, DBS may be better. Slowness or bradykinesia, stiffness or that rigidity, freezing of gait, and then dyskinesias, those extra movements that are a side effect of the medication, and dystonia, or the posturing, toe curling, finger curling. And we can see improvement in all of these symptoms from deep brain stimulation. And additionally, because we can often reduce the medications, or reduce the side effects of the medications, we can reduce those dose fluctuations that happen. So the on and off time that you have from levodopa. And you can also reduce the side effect of dyskinesia from that.
And Dr. Ferris, we had a question as to whether falling can be improved by DBS. You mentioned gait freezing.
Yeah.
Yes.
So the falling is a complex process, and there are certain things that lead to falling that can be fixed. So some people will have improvement in that freezing of gait. If you're not exactly sure what that is, sometimes sometimes it's actually freezing where you can't move your legs or pick them up, but sometimes you can, early freezing can be that sort of bicycle gait where your legs go like this. And the DBS can often help with that, particularly if that freezing is responsive to medication. So if you get more freezing when you have off time, that will be responsive to the DBS. Sometimes people fall because they are shuffling and their feet aren't picking up high enough off the ground, and they might trip over things. And in that case, that is also responsive to DBS. Unfortunately, balance, so the ability to hold yourself upright and to respond to your body being knocked over, is not responsive to DBS. So if you're falling because you're freezing, if you're falling because you are shuffling your feet and you're tripping over things, that will be likely responsive to the deep brain stimulation. But if you're falling because you're just losing your balance, even when you're standing up and not trying to move, that's probably not going to respond to the deep brain stimulation. And I'll talk about that a little bit later. I want to be careful when I talk about deep brain stimulation, because it does sometimes seem almost like magic how much improvement we get, that it is not a cure, and it's not what we call disease modifying as far as we know, which means you still have Parkinson's disease and you're still going to worsen over time, because Parkinson's disease is a degenerative disease, which we have no cure for right now. What the deep brain stimulation does is makes it easier to live with the Parkinson's. Another thing to keep in mind is that we can't, except for tremor, we can't usually make you any better than you feel when the medication is working the best. So however you feel when you feel the best on your medication is usually as best as we're going to get you with a deep brain stimulator. Basically, we reduce medication off time fluctuations, or we reduce those side effects like the dyskinesias in that on time, but we're not going to make you be able to move better than your best time. What symptoms don't improve with surgery? And that's important to talk about, because it's not a panacea. It is best at treating motor symptoms of Parkinson's disease. So the tremor, the slowness, the stiffness, some of the gait problems that we have. It does not treat cognitive problems. So if you're starting to have memory problems or processing problems, it will not help that. And sometimes it can even hurt that. It can make those worse. And it won't help depression, anxiety, apathy, the psychiatric symptoms that can come along with Parkinson's disease. If you're having that freezing of gait when your medication's working really, really well, it's probably not going to treat that as well. If you're having problems with your speech or your swallowing, it's not going to help with that. The speech, sometimes people will notice that their volume gets a little bit louder when they're on the DBS, but it's not a guaranteed improvement. And as I said before, balance does not improve with surgery.
And Dr. Ferris, somebody's asked whether orthostatic hypotension would be improved by surgery, and how about falls due to orthostatic hypotension? And maybe you could say what that means.
Yeah. So in case you don't know, the orthostatic hypotension is a symptom of Parkinson's disease that can happen when your autonomic nervous system that controls your blood pressure isn't working very well. And what often happens in Parkinson's disease is that when people go from lying down to standing up, or from sitting to standing, or climbing stairs, or going up a hill, their body doesn't compensate well for that change anymore, and their blood pressure drops low. So some people, you may notice it because you get dizzy or lightheaded when you stand up too fast, or you may actually have noticed that your blood pressure is quite low. Sometimes people will drop into the 70s or 80s systolic, which means that your brain isn't getting enough blood, and you get dizzy and get symptomatic from that. So it's an interesting question. There is some evidence that the DBS can help with some autonomic symptoms at times. There are papers describing people whose orthostatic hypotension or whose hypertension have both been improved by DBS surgery. but it is not a guaranteed effect. And in fact, because it's not guaranteed and we don't know exactly where to place and how to program for it, it would not be, I would not usually say it's an indication by itself for surgery. If you're getting surgery to treat other things, the orthostatic hypotension is not usually a contraindication. How it can help for most people is that once you get the DBS, you're often able to reduce your medications. And carbidopa, levodopa, or Sinemet, or Rytari, or even some of the like Referral, most of the medications that treat Parkinson's disease can lower the blood pressure and make orthostasis worse. Your doctor will still probably give it to you because you need to be able to move around, but they may be giving you another medication to treat the low blood pressure. When you get the deep brain stimulation, we're often able to reduce the medications enough that your blood pressure can get a little bit better and you may not have as many problems with it. So it's kind of an indirect treatment by changing the way you take medication. And thus, if you could take medication and you can get your blood pressure higher, it may reduce the falls secondary to that. So how long will the benefits, if I get deep brain surgery, how long was that going to last? So the evidence in our paper, and when you look at research, is that most people, when you look at population studies, are going to have improved functioning for 15, 16 years. That doesn't mean that you're going to be doing fantastically well for those 16 years. But if you look at a group of people that had DBS and a group of people that didn't have DBS, the people with the DBS are going to generally be doing better than the people without it for about 16 years. After 15, 16, 17 years, the difference between those groups starts to normalize and you can't tell the difference anymore. It's not that the people with DBS are doing worse at that point, but just that it's harder to tell the difference between those two groups. And that also may be related to the fact that most people get deep brain stimulation at certain times or time in their disease course. And so after 16 years, that's often when people are developing some of the extremely difficult complications of Parkinson's disease that we can't manage with. There isn't very much to do to help with them. So this is just a graph that's talking about how well people are doing off their medication, why we can reduce some of their medication after surgery. So you can tell before the surgery, these people had a big difference in how well they were doing before off their medication, which is this gray one. They were not doing very well, and on their medication, they were doing pretty well. After the surgery, you can tell that there's much less difference between off time and on time. And this is just 3 years out, not the 16 years out. But we do think that this difference holds true for at least 5 years. And this is kind of an older slide, but it's a good thing to bring up. The battery for the pulse generator, it used to be that it was just a battery and it had to be replaced every few years. Now they are rechargeable, but everyone's need to recharge or need to get it replaced is different because of your settings are different. So some people may need to charge every other day, and some people may need to charge only once a week. And when it was replaced, some people need to be replaced every 2 or 3 years, and some people could go 5 or 6 years without having it replaced. So it is a surgery, it's a brain surgery, and there are risks anytime you're going to do a surgery. So these are the statistics, average statistics from population. Each surgeon will have their own specific surgical risk that they can report to you. Sometimes it is actually lower than this, and occasionally it's a little bit higher, depending on the population that a neurosurgeon will see. So there's a risk of bleeding, and we call that hemorrhage in the brain. They're often very small, but there is a risk of a large one. There's a risk of infection. So we're cutting open the skull and we're putting something down into the brain, and that's a risk. One thing that can be related to this is we do most of the time ask people to shave their heads. And one of the reasons why is because hair in the area increases the risk of infection. Not every surgeon will ask you to shave your head, but just to be aware that if they do, that is why, because they're trying to reduce your risk of getting the leads infected. If the lead going down into the brain seems to be infected, it does have to be pulled out because it's a foreign body in your brain, and we don't want it to cause brain infections. Sometimes there can be mechanical or hardware problems where the lead or the controller isn't working correctly, and that has to be replaced, or something has to be redone during the surgery. And then there can be some changes in thinking and behavior. Part of these are risks are related to the location that we choose, whether it would be that STN or the GPI. Some of them are transient. People feel like for a month or 2 months, their thinking's a little bit cloudier, and then they kind of got back to where they are. And some people feel that it's a more permanent change after they get the DBS. So one of the things we do when we're considering whether to do DBS for someone is whether they're already having cognitive or behavioral changes. We usually will get some kind of evaluation. Here at Stanford, we do a neuropsychiatric battery, and we do full cognitive testing. And to make sure that there aren't already problems. If there are problems in thinking or behavior, we may choose a different site, or we may ask to do what we call a tiered or a slow procedure where we only do one side at a time, because the risk is a little bit lower when you do one side. So overall, the indications why someone might get deep brain stimulation done: you need to have Parkinson's disease. And it says idiopathic here, but if you have one of the genetic forms, that's okay too. You generally need to have some off and on phenomenon or some dyskinesia when you are on. Motor symptoms that are bothering you, so tremor, slowness, stiffness, gait problems that we can't manage with medications at this point, or the medications are causing some side effects like low blood pressure or dyskinesias. Except for tremor, you need to have a good response to the carbidopa-levodopa or the Sinemet. And we'll talk about that a little bit later. And then we generally do not do surgery in someone who already has dementia, who has untreated depression or psychosis. And I didn't talk about here, but there can be some medical reasons why they may not want to do surgery as well. If you're high risk for infection because you have had a heart transplant or a lung transplant and you're on chronic immunosuppressives, that may be a reason why we wouldn't want to do brain surgery and risk having a brain infection. Okay. If you decide to do it, what can you kind of expect from it? So usually the surgery is a two-step procedure where they do first the brain part and then they do the chest part, the controller. The brain part, and I don't know if I was going to talk about this later, but I'll just say it here. The brain part we can now do either awake, which is the traditional way to do it. We used to do them all with the patient awake, but now we can do some asleep as well. And there are reasons to do one versus the other, and that's something to discuss with your neurologist or your neurosurgeon. And then after that's done, you usually go home, and then about a week later, they under general anesthesia, so everyone's asleep for this one, they put in the controller. And the reason you're put asleep for that one is because we push a wire under your skin, which can be quite painful. So we'd rather have you be asleep for that, and there's no reason for you to be awake. During the brain implantation part, it can be useful to have you awake because we can do an exam while it's going on and see if you're having improving symptoms. And And then the third part is that you'll go back to your neurologist, whoever is going to be managing your deep brain stimulator, and they will turn it on and start to program it a few weeks later. Some people do it as early as 2 weeks. In my experience, the average is that we want you to wait about 4 weeks before we when you go in for the surgery, you'll usually arrive early on the day of surgery, and with surgeons, early is early, probably like 5 or 6 a.m. We don't want you to eat on those days because we may need to give you medication to put you asleep. And we'll talk at Stanford, we have a list of medications and when to stop them and what to take. And make sure you discuss with your neurologist what you should take and should not right before the surgery, because some of them, we want you to be off for the surgery. So some of the medications have to be stopped a day or 2 early. And the surgery may be while you're awake or maybe while you're asleep. If you're awake, you're going to have, this is an old frame, and I'm sorry about the picture being so old, but we're going to have a frame that's put onto your head for many of these. Not everyone does. Some of them are frameless now too, so you wouldn't have to have this. But basically it's just things that are screwed down into the skin, and it's so that we can find the right part of the head on imaging and outside. This is just so you know, after you get DBS, you can still get MRIs, but you have to go to special sites that can do them correctly. And then we use imaging and we use microelectrode recording, which I'll show you in a minute, to make sure we're putting the lead down into the right place. And this is just an example. These green things are the leads going in, and we've done targeting so that they end up in the right place. This is a very old system that we used at Maryland, and the Stanford one looks much fancier than this, but we basically, when we put the electrode in, we're looking for the actual electrical signal that the cells are sending, and that tells us where the electrode is in the brain. So we can tell where we are by what we're hearing and seeing from your brain. And if you're awake, you can actually see your brain firing, which is pretty cool. So the surgery, we drill, you open the skin up, you drill a hole that's very small. It's about the size of a dime. Sometimes people find that to be the uncomfortable part because it kind of shakes their head while it's going on. And then we put a little plastic piece in that supports the skull and holds the wires in place. The wire goes in, and then we do a bunch of testing while the wire is in to make sure we're in the right place. And then once that's done, they close it up and we do the other side. Afterwards, you usually go to either a room or sometimes an ICU, depending on your risk factors. And most people will go home the next day after their surgery. Sometimes they need to stay a day or 2 if there's some concerning issue. And then a few days later, a week later, you end up getting the placement in the chest. That's under general anesthesia. It's an outpatient procedure, and most people do not have to stay overnight for it. And then a few weeks later, we will turn on the stimulator and we'll adjust it to try to help with the symptoms. That first one can be a fairly long visit. Sometimes it works really well initially, but we try to go through all the different possible settings to find things that work well for you. And then afterwards, we'll continue to adjust. So we often, in the first 6 months, you'll have to do it a few times to find good settings for you. Everybody's a little bit different. And then as time goes on, we usually have to do fewer adjustments. And then also in these visits, you'll be asked to be off medication for the most part, which I know is difficult for some people to imagine. But once you have the DBS going, it's not as painful to be off your medication. So some people even notice improvement after the surgery before the stimulator's turned on. This is often temporary, some people call it the honeymoon period, or it's actually a lesional effect, which means when the electrode went in, it caused a little bit of local inflammation that has the same effect as the electricity laser. But it's very cool when we turn it on because people often feel remarkably better the second we turn it on to the settings. And people can sometimes have trouble walking in and can walk out more normally. But as I said, not everybody do we get right on the first time. And so it often takes a few programming sessions to really get it to optimized. Just statistics, off time is reduced by about 83% in most of the papers. We can often reduce medications by about 30 to 40%, and depending on the location, that may be higher or lower. And then people just generally feel better and have better on time with less dyskinesia, and they can take less medication, so their blood pressure may be better, or they may have less nausea. Just to remind you again, it does not cure Parkinson's disease. It doesn't stop the progression of the disease, but it does make you feel better and more able to deal with the symptoms of the disease. And with deep brain stimulation, we can adjust it over time. So as the disease progresses, we can increase the settings or change around the settings. And once again, it's not going to be better than your best on time before. So shifting gear a little bit, focus ultrasound.
Just ask a question, Dr. Ferris.
Yes, of course.
I know one gentleman who has absolutely no response to medication. So he doesn't really have an on time, yet DBS works for him beautifully. Is he a rarity? Does this happen very often?
So with tremor, that is often, that happens a lot of the time. So tremor is one of those symptoms that some people have response to levodopa, but a lot of people don't really notice much improvement. And DBS is a really good treatment for tremor, probably better than levodopa. Yeah. In terms of other symptoms, you know, if there's no response to levodopa in the bradykinesia or the rigidity, that's one of those times that we actually worry that it may not be Parkinson's disease, that it may be something else. It's not an absolute, but it's one of those things where we have to think about it. And we do know that DBS is probably not as effective in some of these mimics, these other disorders like MSA or CBS or PSP. But if you were very sure that it was Parkinson's disease for whatever reason, and the medication wasn't working, we could potentially put it in. The caveat is that for insurance purposes and to be considered a good candidate, you usually have to show at least a 30% change on your on and off UPDRS. So that's the scale that we'll do with people where we have them tap their fingers and open, close their fists and flip their hands over. On that scale, we have to see a difference between when you're on your medication and when you're off your medication. And if there isn't one, then there has to be a reason why. For some people, that's because the side effects of the medication are so great that they can't get to a level that we would expect them to have a benefit. So some people get a lot of dystonia or dyskinesia from low dose of levodopa, and so they can't get up to what we think would be a therapeutic dose. And in those cases, we often do DBS because the DBS will give us the ability to control some of those side effects or use lower medication. If there isn't some exception, then we would be less likely to do DBS. And that's a conversation to have with the person who does the DBS assessment when you come in for your on and off exam. If they don't notice any difference, that would have to be a conversation between the patient, but the vast majority of the time we're going to recommend against DBS just because it's probably not going to give you that much benefit.
Okay, a couple more questions.
Like I said, there are some exceptions, but
yeah, a couple more questions. In the case where it is a tremor that the person has, but the tremor does not respond at all to levodopa or Cinemet. How, and so therefore there's no 30% difference in on and off time. How can that be approved by insurance then?
So in that is a special case where we say that it is medication or treatment refractory tremor. And having that is an indication for deep brain stimulation.
Okay.
So you don't have, so you don't have to show the change in the UPDRS.
Okay,
in
good.
those.
Another question, somebody writes, immediately after surgery, when the patient goes home, how capable is the patient to take care of his or her daily tasks? Do they need help at home after the surgery?
So the initial surgery, the brain surgery that we do is actually, I don't want to say it's non-invasive because it's obviously invasive. We're putting a lead down into the brain, but it's not a high stress surgery like having an abdominal surgery or a heart surgery where we're moving lots of stuff around in your body. Usually we say take it easy for a couple of days, but you're easily able to get up and go to the bathroom on your own or feed yourself, things like that. It's just, I would suggest you're not picking up heavy weights or things like that. And we generally say take a couple of days off before doing sort of high intensity exercise, stuff like that. But you're generally able to take care of your own needs for pretty quickly afterwards. Generally, we won't discharge you from the hospital unless you're going to be okay walking around on your own.
Right. Okay. Thank you.
Yeah. Any other questions?
No, that's it for right now.
Okay. So this is the focused ultrasound part is new. And you may not have heard very much about it. It is something that I've been working on and that we at Maryland did a lot of, and it has been mostly applied to essential tremor, and it's just now becoming more, there's more interest in it in Parkinson's disease. So I'm going to talk about what it is and what it's like, and then talk about why one might choose focused ultrasound versus deep brain stimulation. But I just want to put that caveat out here that deep brain stimulation has been a mainstay of our treatment for Parkinson's disease now for more than 15 years. And focused ultrasound is a much newer technology, and there's a lot less data involved in it so far. So, where deep brain stimulation is, and I'm sorry, I just realized this slide just got copied directly and it should not have. Okay. So focused ultrasound is an emerging new treatment. It's a non-invasive therapeutic technology that could have some of the same effects as deep brain stimulation. Instead of drilling through the head and putting an electrode in, we use sound waves from outside the head, and we send lots of sound waves in, and where they meet, it heats up and actually burns away a little part of the brain. So this harkens back to what we used to do before deep brain stimulation, where we put an electrode in and put an electrical current through. We used to go in with that lead and burn away a little part of the brain. So you'd put a hole in the skull, put a wire in, and burn away a little part of the brain. Now we can do that without having to cut the hole in the skull. So it uses 1,024 high frequency sound waves that meet each other. And when they meet, they cause energy, and the energy heats up the brain and causes a little stroke, basically, in just a very precise area. It's relatively non-invasive in that we don't have to cut open your skin or your skull. I say relatively non-invasive because we are still affecting the brain and causing a lesion in the brain. And we do have to shave your head still for it. And it is an outpatient procedure. So while in DBS, you usually have to spend at least one night in the hospital, this is you come in the morning and you're usually discharged home the same day. As I said, it's currently mostly used for essential tremor, which are the two on the left side of this page. And it's been approved for one-sided treatment of essential tremor, and actually was just in the last month approved for the second side for essential tremor. It has been FDA approved for unilateral treatment of Parkinson's disease, so only treating one side right now. And for both tremor or for the other signs of Parkinson's disease like rigidity, bradykinesia, dyskinesia. Unfortunately, and I'm not 100% sure this is up to date, but the medical system is very weird, and that the FDA will approve things, but it often things won't get paid for until CMS or Medicare approves it. And that process can be very long. And as far as I know right now, Medicare has not yet approved either of the treatments for Parkinson's disease, but it is FDA approved, which means we're allowed to do it, but no one will pay for it. So some people do choose to pay for it out of pocket. Most people can't afford that. But once it's been approved by the FDA, CMS will eventually approve it. So it's just in the next year, 2 years that it'll come out and be. So I talked about the areas of the brain last time, and this has similar targets. So we can target the GPI or the VIM. In this case, we do not target the STN, and that's because when we cause lesions instead of stimulation, it can cause side effects that are unpleasant, though there is research being done in it, but that has not been approved yet. And there's also another trial being done right now that I'll talk about a little bit more, that instead of being a nucleus where there are cell bodies, it's actually targeting the tract, which are the connections between the areas, and knocking out one of those tracts. This is an interesting target because it's not something we can do with deep brain stimulation. With deep brain stimulation, we have to target cell bodies. So with focused ultrasound, we can sort of, instead of targeting the buildings, we can target the road between the buildings, whereas deep brain stimulation has to be in the buildings. This trial is called the unilateral or bilateral palatothalamic tractotomy. It is not recruiting right now, but it is in the midst of being done. One of the interesting things about this trial is that it is bilateral. So the trial was set up to be able to treat both sides. So whereas these ones right now, we can only treat one side, on this one, we would potentially be able to treat both sides. And most people with Parkinson's disease, when they're looking for some kind of intervention, are having bilateral symptoms. So this could potentially be helpful. The data has looked reasonably promising so far, and it's ongoing my guess is that it should be done in the next year or two, and then we can have the outcomes for that. So what symptoms can be improved by focused ultrasound? It's similar to DBS. The VIM target is targeting tremor, and like Parkinson's, like the deep brain stimulation, you can actually have improved tremor control to medication. In terms of other things, the trial with GPI was done mainly to treat unilateral or very asymmetric dyskinesias and dystonia. But while that was the main reason for doing it, they did see improvement in slowness or bradykinesia and rigidity as well. So we saw that in those off UPDRS scores, there was improvement, and there was improvement in quality of life for people who did this. But a limiting factor, as I said, is that right now it's really only approved for one side. So the current state of affairs is that it's not applicable for most people unless you tend to really have much worse symptoms on one side than the other. It's not a cure, just like DBS isn't. In this case, you are while deep brain stimulation often has a large reduction in medication, this is probably a more modest reduction in medication. But because there's a reduction in dyskinesia and dystonia, you may actually be able to increase the medication and get better treatment if you had these side effects that were limiting your treatment before. What will not be improved by treatment? As I said, you're not going to get rid of medications, and all the same things that can prevent you from having deep brain stimulation can also, or that aren't treated by deep brain stimulation are not going to be treated by focus. And how long will the benefits last? And this is something we don't honestly know the answer to completely yet. The first studies in essential tremor were done a little over 10 years ago, and there are people still with some benefit 10 years out from essential tremor. The Parkinson's trials have been much more recent, so I think the longest we have out for that is about 4 or 5 years, and there are still people with benefit at that point. Because this isn't something we can adjust like a deep brain stimulation, this is a one-time procedure, you're going to notice decline caused by the Parkinson disease itself. And it's a little bit harder to tell we're not changing the slope, we're just moving it differently. So with the decline, so it's a little harder to determine group changes. But we think that people are still seeing some benefit at least 2 years, and we know that they are with tremor. In tremor, sometimes people can only have a transient benefit that goes away, and we're getting better at that and determining why that is happening, but that's always a risk as well. What are the side effects? So during the treatment, you do have to be awake for this one. You can end up with some sort of treatment-related side effects, which are nausea or vomiting, headache, head pain from having the thing on your head. And then these numbers are just coming from a small trial that we did, the first pallidotomy trial. But other potential risks are some people have some worsening fine motor control, some speech changes, and some balance difficulties. These risks we know can be related to the lesion size, and there's a lot of research going on to reduce these while still getting better symptomatic treatment. But it's always a risk that you could have worsening of your voice, like the slurring of your words, or potentially worsening balance problems. So who would potentially be a candidate for this? People who have Parkinson's disease, people with asymmetric symptoms right now. In the future, that may not be an indication. People who are responsive to levodopa and who don't have dementia or depression. I will say that the evidence, I'm actually working on writing up the cognitive data for this. The sample sizes are still small, but there probably is less cognitive effect from focused ultrasound than from deep brain stimulation. So in the next few years, it may come out that this is a better procedure if you're already having some cognitive problems than deep brain stimulation may be. That always has a caveat that we also have new deep brain stimulation technology coming out, but it's something to keep in mind that this procedure sometimes is a better procedure for people who have some contraindications for deep brain stimulation. And what would you expect from it? There's some initial workup to ensure candidacy. You have to get a head CT, you have to see a neurologist. The treatment itself is a one-day outpatient procedure where you'd come in the morning, usually pretty early, and then you're usually going home the same day. And this is a one and done procedure. So you come in, you have it done, and then you go home, and you don't have to come back for the other surgeries and the other adjustments like you do for deep brain stimulation. So you do head CT, you have to be able to get an MRI done. So if you have a MRI non-compatible pacemaker, we might be able to do DBS for you, but we will be unable to do focused ultrasound because you have to be able to be in that MRI machine. You can discuss with neurosurgery, you can talk to your neurologist about this, and then eventually we schedule the procedure. So there's a little bit less workup than is required for the deep brain stimulation as well. This is just kind of what it looks like. So you lie down on this table, your head is attached in here. It's like a helmet. And you can see there's like a gasket here, this plastic thing, and there's actually water running through that. So water is pretty cold, which is gives people headaches because there's cold water on their head. And there's a frame attached to your head. You do have to shave your head, unfortunately, for this as well. And that's because the sound waves have to pass through the water efficiently, and hair can interrupt with that. And then basically you sit in an MRI machine and we move you in and out and do stuff to you for a while. So another contraindication is if you can't lie flat with medication, we can give you painkillers if you have back problems. But if you can't lie flat for more than an hour or two, then this may not be the procedure for you. Sometimes people with lung problems or heart problems have that. So we'll ask you to come in. We usually ask you to shave your head on your own for this procedure, whereas DBS, we often do it ourselves. And then they may clean it up. You'll have the frame placed on your head. You'll lie down in the MRI. We'll do kind of funny exams where we have you write, where we have you move your fingers and move around. And then we'll disappear for a while because we're planning out what we're doing. And then we'll come back and forth a few times. During the sonication itself, we'll give you some warnings. Sometimes people experience nausea, vomiting. A lot of people say it feels like they're on a roller coaster where their stomach kind of jumps up and that's why they feel nauseated from it. But the sonications are usually fairly short. So they start out at about 10 seconds and they get longer as the procedure goes on, but they're usually less than a minute. So you may feel nauseated during the thing, but it's not like it's ongoing for 2 hours. And then the whole thing usually takes, once you're lying down on the table, between 2 and 4 hours, usually towards the 2-hour side, but occasionally some of them run longer. And like DBS, you go back to a recovery room, make sure you're okay. Sometimes people have some transient difficulty walking and balance issues, particularly because they've felt dizzy from this. We make sure that you can walk before we send you home, and then you get to go home. And with this procedure, you see immediate improvement in symptoms. So we actually are looking for them when we're doing the procedure. So you go home knowing how much you're going to improve. And results will see potentially less off time, improved quality of life. We may be able to reduce your medications or have fewer side effects from the medications like dyskinesia. And like DBS, focused ultrasound does not cure the disease and it doesn't change the course of the disease. This is a one-time procedure, so we can't adjust like we can with DBS. So stop there for a second and see if there's any questions about focused ultrasound. If anyone, this is a newer thing, so you may not even know to have the questions, but I like to bring it up because I think it's a promising treatment that's coming up for.
Yeah, a couple questions came up. One person says, well, since the FDA has only approved it for one side on Parkinson's disease, and you said something about most Parkinson's patients would want bilateral. Who right now would be a good candidate for this? Would it be younger people who just have symptoms mostly on one side, or what?
So there's a few people that might choose to do this rather than deep brain stimulation. The first would be if you can't get deep brain stimulation. So some people who can't get deep brain stimulation are poor surgical candidates. So someone who has a heart or a lung transplant or any other kind of transplant where they're on chronic immunosuppressives, doing brain surgery on those patients can be scary, and it's up to the patient and the surgeon, but oftentimes the surgeon is not comfortable with it. So this might be an option for them. Deep brain stimulation is more dangerous the older you get. And focused ultrasound does not seem to be more dangerous the older you get. We don't have as much data in Parkinson's disease, but in essential tremor, I have done this procedure on someone who is 95. And I would never do deep brain stimulation on a patient that was 95. So because you're not cutting into the skull, you don't have the same surgical risks associated with anesthesia and things like that. It might be a good procedure for someone who really does have one-sided symptoms, and it's rare, but there are people out there who just really, it's just their right or their left side that's bothering them, and this might be a good candidate for them. I'm also bringing it up because I do think it's going to be approved for the second side, and probably in the next few years. So this isn't for many people, this might not be something you would get done tomorrow, but being aware that it might be an option in a few years can be helpful just as you think about as the disease progresses. I'd say those are kind of the most common reasons one might choose to.
Okay, and somebody asks, would it be possible to get focused ultrasound first, see how that goes, wait a few years, and then get DBS?
We have not, well, I'm not saying anyone has. I have not done it in Parkinson's disease, but I have done that for people in essential tremor, and I suspect that we're going to be doing it in Parkinson's disease as well. So essential tremor, I've done 3 people who got it done for essential tremor, and either it was not effective enough and they went on to get deep brain stimulation, or the symptoms started to worsen again and they wanted something more adjustable and they went on to deep brain stimulation a few years later. So as I said, this is still new, and not that many people have had the focused ultrasound done at all, much less then had DBS. But I do think that that's going to be an option in the future. There's nothing about the focused ultrasound procedure that prevents you from having DBS. And reversely, we cannot do the focused ultrasound on someone who still has DBS in, but it is possible to potentially pull out the DBS and then perform a focused ultrasound on the brain.
Okay. And for those 2 patients you mentioned who had essential tremor, where you did focused ultrasound first and then later DBS, did they both see improve? I know it's totally anecdotal, but did they both see improvement on DBS?
Yes. So both of them actually were quite happy when they got the DBS.
Okay, interesting. Yeah. All right. And would that process also have to be FDA approved?
The focused ultrasound and then DBS?
Yes.
No. So they're separate entities, and the FDA wouldn't feel that they needed to approve of that because it's not. They're not linked. They'd be separated in time.
Okay. Somebody asks, for focused ultrasound, is there a problem from the procedure? If there is a problem from the procedure, is the problem permanent? For example, the side effect of loss of balance.
So that's a really good question. It depends. So the vast majority of people who have side effects from the procedure, they're what we call transient. So they last from anything from an hour to 2 or 3 weeks. But there have been people who have had more permanent gait dysfunction. I will say I have never seen one of those people. None of my patients have had that complication, but it is a theoretical risk. And we are getting better at knowing when that's likely to happen. Some people are more aggressive with how large of a lesion they give, and it does seem to be higher risk with a larger lesion. So if this was something that you were interested in doing, and that was one of the concerns you would have, it would be important to talk to the neurosurgeon about how comfortable they are avoiding that type of risk. So I just performed one of these on Monday. This was for an essential tremor patient. And the patient was very clear that they wanted to decrease risk rather than maximize benefits. So they were willing to have a little bit of tremor left and have no side effects. So we stayed on the conservative side. And that's a conversation that you could have with your surgeon one way or the other.
Okay.
So I think this gets to some of the questions that people were having, but I do like to sort of compare them directly, since it's two options that do similar kinds of things. So when you compare DBS and focused ultrasound, on the DBS side, it's extremely durable. We know that people are still getting benefit 15 years out. You can have it done on both sides, and it's adjustable. So over time, as the Parkinson's worsens, you can change the settings and help the symptoms better. You can also turn it off. So if you're having side effects from something, we can turn it off and see if the side effects are coming from the stimulation, and then change things based on that. On the other side, it has some higher risks. So it's a surgery, so it has a risk of bleeding and infection, which are usually pretty mild, but they're not negligible. And I have seen someone with infected leaves that had to have it taken out. There are multiple surgeries involved. So you have to come in and do the brain, and then you have to come in and do the chest, and then you have to come in and do the programming, and you might have to do a number of programming over time. In general, in an urban area like this, it's not as terrible for people to be able to come into their doctor that often. But for someone who lives rurally, who has to drive 8 or 9 hours to get to a movement disorder specialist, DBS might not be a very good option for them. And we have fairly strict criteria, and that we really don't, we really look carefully for cognitive issues, psychological issues, your surgical candidacy. So you can't be on suppressants, you can't have severe disease. On the other hand, focused ultrasound, we don't know yet, but it's probably less durable than a DBS, just because we do something and then the brain can heal somewhat. Right now, we really only have a unilateral treatment, though I do think that's going to change. Once it's done, and we can't really change it. We can't get rid of the side effects that are there, and we can't usually improve symptoms anymore. But we don't open the skull up, so there's no bleeding risk. There's no infection risk at all. I should say there's a lower bleeding risk in that you don't bleed on your skin, but there's a small chance that you can bleed inside the brain. It's a one-time outpatient procedure. So for someone who has trouble accessing healthcare, or who lives rurally, or who really just can't, I had one person who chose to do focused ultrasound over DBS because they were the primary caregiver for their spouse, and they were unable to really even take one day to be in the hospital. So this can be something that's an option for someone who, for whatever reason, just can't spend that much time interacting with healthcare. Excuse me. And the patient criteria is a little bit less strict. There's probably less cognitive effects from the focused ultrasound. We know that there's less surgical risk. We've done the procedure in much older patients, and patients who have other comorbidities that prevent them from getting deep brain stimulation. And I didn't address this, but some people are just really afraid of having something in their brain, having a wire stuck into their brain, or having brain surgery. And focused ultrasound may be a little bit more palatable to them. In general, if you're a candidate for DBS right now, particularly, but that's probably going to go on for the future, I think DBS is probably a better option. But focused ultrasound can give people who either can't have DBS or are unwilling to have DBS another potential tool in the arsenal for treating the symptoms of Parkinson's disease. That was really all I had. So I'm happy to answer questions about this, about anything else procedural associated with Parkinson's disease. I think of myself as an interventional movement disorder neurologist. So I treat Parkinson's and I use medications, but I really like some of these alternatives to medications as well, because I think it can give people a really improved quality of life.
Okay, Dr. Ferris, thank you very much. Could you go back to the previous slide, just
Yeah.
one before? So I noticed that for focused ultrasound, do we have an acronym for focused ultrasound? Is it called FUS or something like
Yeah,
that?
you could call it FUS. It can be really long. Sometimes people call it MRG FUS, which is just too long. So FUS is usually the
Yeah,
one.
okay. I saw the MRG on one of your slides. That seemed very long. Okay, and it says side effects can be permanent. And I recall that was nausea. That didn't sound like fun.
So the nausea is not
Okay.
not permanent. That's only during the procedure. So the nausea, the vomiting, the dizziness is intra-procedural. That makes you dizzy. The side effects that potentially could be permanent are the most common one initially, though, has gotten much better and would not apply as much to Parkinson's disease, was just some numbness and tingling in the hand. Sometimes a little bit of slurred speech, what we call dysarthria, and then the balance problems. And as I said, that is a rare side effect, but has been described that people can have permanent problems with their balance.
Okay. All right. And if anybody has more questions, they could type them into the Q&A box or the chat box, whichever should work fine. Okay. Somebody asks, at a center like Stanford or UCSF, are there protocols or does each surgeon choose the device, etc.? And I think maybe the person's asking about Boston Scientific versus Medtronic, perhaps.
Yeah. So I can answer the question both with DBS versus focused ultrasound and within DBS.
Perfect.
So at our bigger centers, we have a neuromodulation team, which is made up of the neurosurgeons and then the movement disorder neurologists who are involved in neuromodulation. And then often actually also our neuropsychology team, sometimes psychiatry if they're involved. And we have a meeting twice a month where we discuss cases. As of yet, we've been mostly just talking about deep brain stimulation cases, but at Stanford, we've been talking that we'd really like to add in focused ultrasound so that we can talk about both. And if we don't just say no to people if it's DBS, but then we can discuss whether focused ultrasound might be a good option for them instead. And during those meetings, we talk about the case, so the patient, how their disease presents and what they're looking to improve with the DBS. So some people want to reduce their medication, some people just want to feel better, some people want to walk better. And we talk about whether those goals are realistic given what we know about the disease. We talk about what area of the brain we would want to use as a target. So most people, it's going to be STN. That's the first thing we talk about, but there might be something that would suggest to us that we should use a different target, and we'll talk about that. And then we sometimes talk about what system to use. Now, every surgeon has the systems they like better. And that's usually related to how easy the hardware is to put in and how reliable it is. So there's always some failures and they may have to redo part of the surgery because one of the pieces of hardware stops working, and no surgeon likes to have that happen because it can make the surgery go longer and it can increase the risk of complications for the patient. So most surgeons like certain hardware better. With that said, at least at Stanford, they are happy to talk to you about the different options, and it should ultimately be the patient's decision. The three systems that we use for DBS are Boston Scientific, which is probably the most frequently used right now, Medtronic, which is probably the second, and then Abbott, which is the third. The reason Boston is used the most right now is because their hardware is really good. Things don't tend to fail. They tend to do well. They have a really good chargeable battery that works well. And then also they were the first system to come up with directional leads, which makes it easier for the neurologist to program. Medtronic is the second one. It also has good hardware. It also has good programming, and it also has directional leads now. But it was sort of not as fast to get those things. And the surgeons, most of them got attached more to Boston. On the other hand, for future area of DBS, and I think this is coming up in the next year or two, Medtronic has been working very hard on a project that is, so we talk about closed loop and open loop systems, and Medtronic is developing a closed loop system where the machine itself reads output from your brain and changes settings based on what it's reading. So it involves less of the neurologist having to go in and change settings. And that system is looking very promising. So I think that when that system comes out in the next few years, we're going to see a shift where a lot more people go to Medtronic over Boston at that time. Abbott has a special feature and has been probably bumped up more in the last year or two because Abbott has come out with a remote programming. So that means that the doctor doesn't have to be in the same room with the patient to be able to program it. And some people, especially in rural areas, are excited about that ability because it means that maybe people can have access to DBS that didn't really have very good access before. There have been some issues with billing and whether it really works as well as it needs to work and things like that. But you know, each system has something that is going for it that's really interesting, and it'll be interesting to see how that shifts over the next few years. But fundamentally, it should be a discussion between the surgeon and the patient, and sometimes the neurologist as well, as to which system would work the best for any individual patient.
Okay, and kind of related to that, we have a few additional questions. Someone asks about something called adaptive stim or adaptive stimulation. Can you say something about that? Does that?
Yeah. So the adaptive stimulation is a part of Medtronic right now too, and that is part of the sort of same research programming as the closed loop system, where the controller itself is getting feedback back from the brain. It's not just sending electricity out, but it's getting feedback back, and it can modulate how much signal it's giving based on what it's getting back. And that's the adaptive part of it. So right now there's some adaptive programming that is part of, that's not just in a closed loop system, that's also in an open loop system that the doctor can program in some of the adaptive programming as well. I do think the adaptive programming and the closed loop systems are going to be the future. I think in 20 years, probably everybody's going to be having that system, that type of system put in. The question right now is really, how good is the adaptation, and how good are the neurologists and surgeons at getting those systems set up in such a way that they work well.
Yeah, and I think Stanford's really been at the forefront working with Medtronic on that closed loop adaptive system. And I think that's the same thing as brain radio, what we had been calling brain radio.
Brain radio, yeah. So
of this done quite a while ago.
Yeah, so Dr. Bronte Stewart has been sort of the head of this and running it. So I could give just some basic updates that I know. I just don't have the specific data of where things are and the dates, but I know that they're planning to present results from the trial that's been going on this summer. So I think I just don't know what I have some data, but I'm not allowed to share it without the appropriate permission and stuff. And so that was the confusion that happened. So, but you can expect to hear some of that come out this summer. I'm like 95% sure that'll be
Great.
start showing up this
Wow.
summer. And then there's been some prediction that it might even be commercially available in 2024. So,
Wow. Okay.
maybe, fingers crossed, but maybe.
Yeah, that would be amazing progress. And that's I know Dr. Helen Bronnie Stewart and Medtronic have worked very closely on that brain
Yeah.
radio project.
Yeah.
That's great. There was another question that related to what we were just talking about, and you kind of hinted at this a little bit. Someone asks, are there enhancements coming to DBS in the near future, which would suggest that I should wait a short time for these enhancements?
So it's always a tough question because DBS is constantly getting updates. So one of the 3 systems will come out with some major overhaul basically every year. So like Boston, in the last few years, they got the directional leads, and then they have an 8 electrode lead. And now in the next year or 2 years, I'm not sure exactly when, they're going to have a 12 electrode lead. Medtronic has been really working on this adaptive stimulation stuff, and I think there's a good chance that's going to come out in the next few years. And Abbott has this remote programming, which means that, if you're on vacation and you have an internet connection and you're in Europe, your doctor might even be able to help if there's a problem. And all of those are really exciting and great things. In general, it's not always best to wait, even if there may be new technology, because the vast majority of the benefits that are going to come from a new technology aren't going to make as big a difference as just having the DBS in the first place. People who had DBS 10 years ago are still very happy they got DBS. And in general, I don't want you to sacrifice quality of life waiting for the next new thing to come out. It's not like an iPhone where it really may make a big difference. Having it is gonna, even just having the not as new one is gonna make you feel a lot better. If you don't really need DBS now, you're just sort of considering it, it might be worth waiting a year just to see what happens with this Medtronic thing. But anytime in the healthcare system, you're waiting for something, there can always be delays. And I wouldn't want you to think, okay, I'm going to wait a year, and then 4 years later, it still hasn't come out, and you waited and you've been unhappy or uncomfortable for those years waiting. I hope that answered the question.
Yeah, I think so. Are there any more questions from anybody? I wanted to ask you one other thing. At the bottom of this slide, it says, if you're a candidate for DBS, and that's probably the better choice. So why do you say that?
Right now, because DBS is bilateral, because it's modifiable, and because there's more data and evidence proving it to be an excellent treatment. Focused ultrasound is more experimental, and we just don't know as much about it. And right now it's really only for one side of the body, and you can't change it. I think for me, I think of it as a really awesome thing to offer people who don't want or can't have DBS. Now, in 10 years or even 3 years, I may feel differently. The palliative thalamic trial that is happening right now looks really promising. And when I see I've seen the data from the patients that I was involved in. So I've seen like 4 or 5 people that had it done. When I'm able to look at the data for, I think they're doing 150 or 200 people. When I'm able to look at the data for all of that, I may change. I may say, oh, this is a really good treatment and we should consider doing this earlier. But I don't have the information yet. And I have the information for DBS.
Okay, that makes sense.
Yeah.
All right. Well, I don't see any more questions, but thank you for the terrific talk, Dr. Ferris. It was great to learn more about FUS and to have your comparison here and to know your thoughts about the direction things are headed. And it's a rare opportunity for us to get all these great details. So thank you so much for that.
Yeah, I'm thrilled to be here. I love talking to patients, and that's my favorite part. Is I'd much rather give a patient talk than talk to other neurologists. So
Well, we appreciate that. You gave a I would say a very meaty talk, but in such a way that we lay people could understand it. So I think it was great.
good. That's what I was aiming for.
Yeah, wonderful.
Hopefully it was helpful.
Yeah, thanks so much. And everyone, will see you next month. We'll see you next month. We have Dr. Maya Katz coming from Stanford, and she'll be talking about I forget what her topic is, but you'll see it on the email. And then we have other speakers lined up for March and April as well. So we'll look forward to that and try to go out. You've got another hour to go out and enjoy a little bit of sunshine before the deluge begins again tomorrow. So
Stay healthy and dry, everyone.
yeah, same to you, Dr. Ferris. Bye, everyone. Good to see you.